Hi, this is Serhat from Turkey, Izmir. As usual, this is a great pleasure to meet with you during these webinars organized by Nobel. I appreciate Nobel, Sanjar and Zanar. They are really working hard in order to do so. And every time we are seeing more and more participants, which is lovely. And also I know Maria is doing a great job in order to translate what I'm saying. And this is let me start this way. This is our fourth meeting. We started with reflux epidemiology and diagnosis. Afterwards, talk about the management of reflux, pregnancy and reflux. Today, the last talk about the reflux spectrum, which is the most difficult one, atypical reflux symptoms. And afterwards, we are going to continue with others. Please meet with us every last Saturday, okay? In every month, last Saturday, I will be here and talking with you guys. Please ask questions as much as you can. Zanar is going to send me your questions from the WhatsApp, and I'm going to check my WhatsApp now. The timer is running, and within the next an hour, I'm going to give more details regarding the reflux, atypical symptoms of reflux, as well as responding your questions. And I'm really looking forward to come to lovely Kazakhstan on the 13th of June. I'm going to be in Shymkent, and the 14th of June, I'm also coming to Almaty again. I haven't been in Shymkent, but I heard great things about this city. And I hope to see you all guys there. And please, let's be taking more and more pictures together. That I'm making a collection of your lovely pictures. Okay, today is the day of atypical GERD's disease. As you know, we have typical symptoms and we have atypical symptoms, okay? And we are talking about this part. Let me start with a very big sentences, very important one. The most common reason of chronic cough and chronic hoarseness, pharyngitis, and laryngitis is gastroesophageal reflux disease, unless there is no clear-cut underlying cause. The most common reason is GERD. Wow, this is pretty important. Now, today we are going to talk about the details. Those are the related stuff: cough, laryngitis, asthma, dental erosions, and chest pain. Those are the possible association between reflux and sinusitis, pharyngitis, pulmonary fibrosis, and recurrent otitis media. I'm not going to talk the otitis media, but let me tell you something interesting. In pediatric cases, they collect the fluid from the middle ear, and they detect the gastric pepsin. Can you imagine that? Gastric pepsin. Then that means pepsin is coming all the way up and going into the middle ear. This is pretty interesting. And a couple of slides will be repeated from the previous talks, but I can tell you that about 23% of the population has reflux disease in adults. Please, repeating again, perform a study in Kazakhstan and in other countries. I know there are other countries listening to this talk. Please tell me which countries they are. Lovely to learn. And it's good to learn the details of the epidemiologies of reflux disease in your countries. However, today's topic is the additional symptoms. This is one of my previous publications. This is the first study from Russia we performed years ago in Moscow about the prevalence of reflux disease. That means our question is already translated and validated for Russian. If you wish to use it, you are welcome. What is the additional symptoms? You see here, asthma is about 6.3%, Argentina, China, very small in Turkey, interestingly. But pharyngeal hoarseness, you see, somewhere around 9 to 29% of the population with GERD define pharyngeal symptoms or hoarseness. Cough is also very common. About 20% of patients in Turkey has cough. and 36.7% in Moscow has cough, in addition to reflux disease. Why is that? Why is that? Because from the embryogenic origin, esophagus, larynx, pharynx, lungs, and trachea share the same origin. In that case, if something happened here, everything goes to the way of to the dorsal vagal nucleus and nucleus ambiguus. And also nerves from the upper airway and lower airway go to the same nucleus as well. In that case, there are two possibilities for atypical symptoms, which we are going to talk about that. There are many reasons, but the one is there is a reflex mechanism here. If the acid and pepsin comes here, some patients feel that they're actually acid and pepsin is inside trachea or lung or larynx and pharynx, and they start coughing, something like that. Okay, this is one of the reasons. However, chronic obstructive pulmonary disease has a different way. In that case, there are too many possibilities, such as displacement of the diaphragm. Diaphragm goes up. Hyperinflated lung change the kinetics of the esophagogastric junction. Also, abdominal muscle using is increasing. And this is another pressure going upward to the gastric content. Sure, there's an aspiration of refluxate. Vagal neuronal reflex, which I just explained, and maybe there is an insufficient swallow, which is debatable. There is another important pulmonary problem related with reflux disease, pulmonary fibrosis. It is pretty important. There are many people with the pulmonary fibrosis. They have reflux disease. We have a center here for interstitial pulmonary fibrosis. They refer us their patients in order to evaluate their patients for reflux disease. Wow, such a very much complicated figure. I'm just going to summarize you the pathogenesis of the atypical symptoms. Abnormal lung mechanics is important. See here. Diaphragmatic displacement, increased abdominal pressure. It's debatable whether there is a delayed gastric emptying. And others, I'm not going to go to the details of this slide, but they all increase the esophageal exposure to reflux because LES and diaphragmatic hiatus, their kinetics change related with the pulmonary problems. Possibly, esophageal clearance is decreased. And then they all increase the proximal reflux, not the distal only, but proximal. But don't think that it's a huge volume. It's just air bubbles. Very small amount of acid and pepsin goes all the way up and produce the symptoms with microaspiration. There is reflex mechanism, just explained, and there is reflux mechanism with a very small amount of acid and pepsin actually aspirated by our patients. We call microaspiration. Central neural sensitization is always a problem. This is why sometimes we use tricyclic antidepressants or baclofen in patients with chronic cough. This is another reason why we prefer such medications. But in your countries and in my country, HP is a big problem, Helicobacter pylori. I wonder once whether there's any relationship. This systematic review showed that actually no, there is no relationship between the HP and laryngopharyngeal reflux disease. I'm still waiting for the question, guys. Go ahead if you have any question. When we have a patient with chronic cough, it's well known that there are three possibilities: reflux disease, asthma, and upper airway cough syndrome. Now they call it that way. These three consist about the 95% of the reasons of chronic cough: asthma, reflux disease, and upper airway symptoms. This is the main trouble in those patients. But many patients also overlap. Patient might have asthma and reflux disease together. And this poor guy, it has a lot of problems. You know, I'm drinking coffee. I don't want to spill it on my hand, which is Stachys squamous epithelium, but I drink it. And I directly contact with with pharynx. I'm talking. Talking is a mechanical trauma. Infections, allergy, some functional problems, very hypertonic food, Turkish baklava, cold drink, hot drink, epithelial defense problems. There is the upper airway, upper part, the defense is about 100 less powerful than the esophagus. Hydrogen ion concentration is 1 to 100. This is a very sensitive area. Alcohol, smoking, dust, and others. When we give PPI, in that case, all we affect is acid and pepsin, not totally. While we discussed in my previous talk, we inhibit the acid a little bit and inhibit the pepsin a little bit, but not totally. Oh, this is an important issue. Many patients actually ask whether there's a risk of having pharyngeal or laryngeal cancer and reflux disease. The answer is, unfortunately, yes. The prevalence of GERD is significantly high. In laryngeal cancer, risk increased 2.2 times. In pharyngeal cancer, it's about 4 times higher. But the problem, we are going to talk in the diagnostics, it is very difficult to establish a causal relationship between reflux and the cancer, because there is no gold standard diagnostics for the reflux in this area. That's the problem. In that case, we assume there's a relationship between those two. Let me drink my coffee, but this is a cold one. You guys go ahead and drink a coffee. You may remember the questions, this slide before the previous talks. There are different diagnostics. For example, PPI trials, upper GI endoscopy. Those are for the regular reflux disease diagnostics. High resolution esophageal manometry, 24-hour pH impedance monitoring, or laryngeal pH monitoring for LPR. We'll talk about that. Bravo capsule pH monitoring. Barium radiology, there is no role for barium in such cases, except to achalasia and except to measure the size of hiatal hernia. And PEP test, which we are going to talk about this later on. And ENT findings, because when we talk about the laryngopharyngeal reflux disease, we are talking about the ENT's eyes. Let's start with the symptoms. Symptoms are different between the typical GERD patients and atypical symptoms of GERD. Please remember what an important point is about the 70% of patients with atypical symptoms. They do not have typical symptoms. If you have a patient with hoarseness or cough, do not expect heartburn or regurgitation all the time. They might come in many occasions without typical symptoms, just with the symptoms of hoarseness or cough or irritated voice. I have an irritated voice. Maybe you realize that. Sorry, I'm having a laryngitis. I just seen by my ENTs yesterday. I do not have reflux, I can tell you, because clearly I got an anti-reflux surgery, but this is a long-term viral infection. And all the postnasal drip, excess saliva, continued throat clearing, those are all the symptoms of extra or atypical reflux disease. Can I rely on the ENT's eyes? Do we have any ENT? I don't know. But unfortunately, the answer is no. Do I refer my patients to ENT? Yes. But I'm going to show you 2 consecutive studies. This is the one. The prevalence of hypopharyngeal findings associated with reflux in normals. This is the funny stuff. This is in normals. You see 80% of patients might have 65, or here 20% of patients have one type of LPR finding. This is more interesting. They refer to 52 non-smoker volunteers, no history of ENT or reflux. 3 different expert ENTs examined them. And look at the prevalence of the different laryngeal irritation signs. Aritonate problem, 76%. Posterior commissure bar, 53%. Pseudosulcus, 37%, whatever. What I understand from those 2 studies is, unfortunately, ENT's eyes are not sensitive at all. For example, this pseudosulcus vocalis just here. If you are doing endoscopy, please always look at the pharynx and larynx. Try to see. This is, yes, a minor finding for reflux disease. This is the esophagus. Those are vocal cords. This is the trachea, okay? An interarytonate area. How about this? Ventricular obliteration seen here. And this patient, closing a little bit weird. This patient possibly also has voice troubles, trying to use the diaphragm in order to give a better talk, okay? From talking from the diaphragm, pushing it, and this is much better. Thanks for this question from Svetlana. I'm going to come to that. But there are some specific findings which really can be attributed for reflux disease, such as granuloma, seen here, okay? Not the erythema, not the interarytonate pachydermia, not the pseudosulcus, but granuloma and nodules. They are much more related with the reflux disease, that's for sure. And you see there's an edema here, even a little bit hemorrhage here, okay? Discuss with your ENT. This is important, what they have. As we discussed earlier, there are many diagnostics. Now we have newer diagnostics. Please, in Kazakhstan, there is a strong need for having newer diagnostics, such as 24-hour pH impedance monitoring, high-resolution manometry, and others. Anyway, for the typical reflux disease, the best diagnostic methodology is PPI trial. Put them on PPI and see what's going to happen. How about atypical reflux disease, cough, hoarseness, or others? Still, that persists. But this is this publication is the Turkish Reflux Consensus Report. I would suggest you, it's open access. Go ahead and read it if you're interested. We suggest everyone initiate a double dose of PPI. For example, put 40 milligrams of pantoprazole and add high dose of alginate, 4 grams of alginate. Please combine it, which we will come back later on for this issue. But this is the best thing to do. Is there any role for endoscopy? Even in the patients with regular endoscopy, there's a few role. Regular reflux disease, sorry. Meanwhile, I'm checking the question. And it's a very low possibility having a diagnostic with the upper GI endoscopy in patients with typical or atypical ones. In patients with typical symptoms, only 1/3 of patients have symptoms, have endoscopic findings, erosive, I mean. For the atypical symptoms, it's even much worse. This is our study. What we are concluding from this study is upper GI endoscopy has no role in the diagnosis of LPR, okay? And there is no indication for upper GI endoscopy unless there's an indication for any other reason. Ainur's asking anti-reflux surgery. Ainur, I'm going to come back later at the end of my talk. This is a new technology, ambulatory 24-hour intraesophageal impedance pH monitoring. This is the catheter. Okay, we put it here. I'm not going to swallow it now, and we have a system like this attached to that. You see, there is a button here. When the patient feels the symptom, they press the button. Okay, this is how we use it, and this is how it works. I'm not going to go to details, but we don't use the regular pH anymore, specifically in patients with atypical symptoms of GERD, because as I said, larynx and pharynx are so much sensitive for the acid and pepsin. 1% of acid and pepsin would be sufficient to produce symptoms here. And also weak acid and non-acid reflux is also symptomatic in a patient like this. Using this technology, I can detect the non-acid reflux episodes. Why it is important, even though it is not acidic, but it is important because if my patient has an aspiration with non-acid reflux, still patient will cough. Or if our patient gets a pH 6 reflux here, still patient will be in trouble. Oh, lovely, Almaty. Thanks for joining, guys. I'm also receiving some pictures. Lovely, lovely. Thank you. And I'm going to answer the questions after this. Another point is for the diagnostics. What I do, if I have a patient with chronic cough, and if I refer to my ENTs and my pulmonary medicine specialist, and if they think this is somehow related with reflux disease, and patient does not respond to the initial therapy, then we perform this test, 24-hour pH impedance. And we tell the patients, whenever you feel you have a cough, press this button. Then we'll look at reflux episodes and cough relationship. If cough comes first, afterwards reflux, like and the reflux, this is meaningless because cough is a refluxogenic behavior. However, if the reflux comes as seen here, afterwards with a cough, okay, then this is reflux-driven cough. And it is all about reflux disease, then we do everything in order to treat the reflux disease. This is a recent study we published in UEG journal. We look at the baseline impedance values between distal and proximal part of the esophagus using this catheter. What we see in patients with LPR, this upper area is actually more affected by the reflux disease and the baseline impedance drops. This is also an indirect finding and another metric, we call it EGE metric for the patients with LPR. Pharyngeal pH monitoring. This is an interesting story. What we do here is, if we really have a high suspicion, then we tell our patients to go and we put a pH catheter, and we tell our ENT colleague to put this pH catheter just in upper sphincter. Okay, 1 centimeter above the upper sphincter. This is a very debatable topic, whether it has a meaning or not. Still, we do it in some patients. If we have a high suspicion, you see this is the pH catheter, and this is what my ENT colleagues put it. Yeah, it may have a value in some patients with if we're sure this is all about reflux disease, then we put it here and we then fix it to the nose and then send patient home and measure for 24 hours. This is ResTech, supposedly a lovely technology. Very short pH catheter, just put it here, see this red bulb, and then that's fine, okay? That stays here, and again, supposedly measure the acid in even the vaporized one. However, a lovely study published in UEG journal, they took 10 total gastrectomy patients, no stomach at all. and 6 of them show pathologic reflux. There is no stomach, no acid. Then where does that one come from? Then no one use Restek. I don't want to use it. This is another interesting technology. Saliva measurement, PEP test in saliva. It's actually innovated from a company from UK, good friends of mine. We have some studies as well. In that case, what we do, patients spit, and then we centrifuge it and apply something and put it here. And it's like a pregnancy test, and see whether some monoclonal antibodies for pepsin bind it and give a reflection. We have a study. We show that it has a value. I'm not going to go to details of them, but when we look at the comparative PEP test studies, PEP test positivity is pretty high in patients with saliva, in patients with LPR. The hypothesis behind the equipment is if a patient has pepsin in the saliva or sputum, then that patient has laryngopharyngeal reflux disease. This is what the technology, PEP test technology, measure it. It's expensive though, and you may need at least 3 tests. What they do, they give the patient 3 samples, okay? And then they send the patient home. Whenever patient feel the laryngeal symptoms, then give a sample, and then the sample goes to the company and measure it. This study actually killed the technology a little bit, but others, including ours, show a nice relationship between the reflux episodes and PEP test positivity. Okay, what can I say in terms of the atypical symptoms of reflux? There is no standard criteria for the diagnosis of reflux-related cough or LPR. There is no gold standard criteria. The worst scenario for reflux disease is the atypical symptoms. Still, we can perform an empirical therapy with PPI 8 to 16 weeks, okay? And when we stop the therapy, if the cough stops, good, with the PPI plus alginate therapy, we continue at least 3 months. Then we stop it. If the cough recurs, this is another criteria that this cough is actually related with reflux disease. And I get another way, if you have this technology, and if you detect a reflux-related cough, then that's also important, and start the therapeutic approach. And also our new metric, baseline impedance of proximal esophagus and proximal to distal ratio, which is significantly lower in patients with LPR symptoms. This is also important. Before I come to the managing of GERD, there are many questions. Thanks for the questions. Svetlana from Oskaman asking that pulmonologists in patients remove the diagnosis of bronchial asthma if GERD is detected. However, pulmonary symptoms persist, dyspnea, cough. Is it right? Are you saying that okay, if there is a reflux disease, your pulmonologist think that this is not asthma anymore? Is that correct? This is what you are saying. This is not correct. Your pulmonologists are not correct. They both might be together. We have an epidemiologic study. We show that actually there is no such a huge relationship, but still some patients might have reflux and asthma together, which is about 26 of patients with asthma also have reflux disease. In that case, it makes sense that we should treat both of them, both diseases together, asthma and reflux disease. You cannot say that those are 2 separate entities. Bibi Gül from Astana asking a similar question. She asked questions before, as I remember in previous talks. Do you think that in most cases of pulmonary pathology with an asthmatic component, reflux is to blame? Not the most, but some. Specifically in patients with nighttime asthma symptoms or patient with cough predominant asthma group. They might have, those groups do not have wheezing, but they just cough. This is one group, and the another group is the nighttime asthma. How about COPD? And if the patient has too many COPD, obstructive pulmonary disease recurrence attacks, then there is a possibility of having GERD. Please keep in your mind. Okay. I'm going to give the response later. Okay, what is the cost of pH impedance monitoring, or do your patients get this study for free? Patients don't pay for it. In Turkey, about 96% of patients actually covered by the health insurance. But nowadays, we have a little bit financial problems, difficult to achieve the pH impedance catheters. One catheter costs somewhere around 100 to 200 euro. 100 to 200 euro. It is costly though. Esophageal candidiasis. This is another question we'll discuss at the end. What is the minimally invasive and painless method in your opinion for pH measurement, and how accurate is it? It depends the reason why you wanted to measure it. If you wanted to measure patient for typical reflux symptoms, you are not interested with the PPI response or atypical symptom, then you may use Bravo. Bravo is a capsule pH monitoring. Please look at my previous talk, two talks before actually, and that's a capsule. I attach it here. I sedate the patients during the endoscopy room, put a catheter, and then just stitch it here. That's it. Lovely. But otherwise, they are all the same. I put the pH or impedance catheter all the way in 5 centimeters above the LES. Those are all the same. The other questions I'm going to answer later on regarding the therapeutic approach. How about in general, reflux management can cover lifestyle changes, medical therapies such as alginates, prokinetics, H2 blockers, PPI, endoscopic therapies, Stretta links, Gerdix, RMA and arms, which I'm not going to talk about the endoscopic therapies because of the time limitation, except there's one question about links, and anti-reflux surgery, which we are going to talk later on. The best lifestyle change is losing weight. Losing weight, okay? It is the best approach if we can do it. I have a big belly though, even though I lose 16 kilograms with Saxenda, but that's always a big trouble. I have some patients, I refer them for anti-reflux surgery, then they lose weight, and their reflux symptoms actually decrease tremendously, which is good. But that's the best thing. How about I'm not going to talk about the typical reflux, but how about the PPI versus placebo studies for cough or laryngitis? Oh, my friend, we have a problem here. When we look at the studies, in many studies, PPIs are equal to placebo in terms of the therapeutic approach for chronic cough. But there are just few studies. What are the reason of it? Why? Can I say that, okay, because PPIs are useless? No, because we have the problem of diagnostic technology. If you don't have any gold standard technology, how in the earth you are saying that this chronic cough is related with the reflux disease? Let me put the patients on PPI, then the patient will completely getting better. That's the problem, my friend. That's the problem, okay? Because there are too many reasons of chronic cough. We cannot easily say that, okay, this is the established diagnosis. How about LPR? LPR is the same. There are too many studies. I'm going to show you some funny data. This is one of the meta-analysis showing that PPI is equal to placebo on LPR or chronic cough. Same here. Another study showing the same results. But remember, nearly none of the data is addressing to use that PPI plus alginate the role of the combination therapy, which I'm going to touch later on, is more successful or not. How about the ENT's eyes? In terms of ENTs, there are two measures: reflux symptom index and reflux finding score. Reflux symptoms index is a question filled out by the patient, which we validate Turkish. Reflux finding score is a scoring system, established by the ENTs while they are performing flexible or rigid laryngoscopy. When we look at this study, there is a tremendous improvement for placebo versus PPI for the reflux symptoms index. And reflux finding score, actually no. Symptoms actually getting better, but findings not. Here come to the two meta-analyses. I put them together regarding all the studies I show it here. There are two meta-analyses, published 2016, published September 2014. The left one saying that PPI significantly improved the symptoms in LPR patients, therefore should be taken into the consideration. Okay, but the other one, using nearly the same studies, saying that PPI had no significant advantage on improving or resolving LPR symptoms over placebo. What we do, I'm going to show you our approach. One of the problems, which you can see here, the place of PPI. This is an old slide, but many people use this. What is the therapeutic gain of PPI over placebo in different aspects of reflux disease? The best PPI responsive GERD phenotype is the esophagitis seen here. This is the best one. Heartburn relief, we are good. There is still a gap. Okay. If there is an endoscopic finding, it's always good. It's always good. I love those. Regurgitation is worse. But remember, this red ones are the gaps. That means PPIs are not effective in that group. 50% relief for regurgitation, because regurgitation is the volume. Chest pain, lovely. Here. But chronic cough, nearly no one improved. Hoarseness, nearly no one improved. Asthma, it's even funnier because it's the other way around. Placebo is insignificantly better. Still, I'm saying that doesn't mean we should not use PPI. I'm going to come back to the end of the story at the end of my talk. Is there any other approach? Yes. This is the alginate. You can use alginate with combination, which we use it a lot, or a single one. Because, alginate actually produce a raft here and protect against the diffusion of pepsin, bile acids, and acid. Pepsin and bile acids are the most important noxious agents for upper airways. In that case, and there are some studies showing that alginate actually cover the epithelium seen here and protect the mucosa. This is how the alginate actually form the raft. This is why I use it a lot. I use it for the regular reflux patients as well as atypical patients. We use a high dose of alginate. We use it. Alginate is one option. N-acetylcysteine in only one study is used. Etopride or itopride, this is a prokinetic agent. You can use it. It's not my first choice though, but it is a possibility to combine, to arrange a combination with PPI, etopride. But I prefer PPI and alginate in many occasions. How about anti-reflux surgery, which you asked for it? If there is a control group, this is our study, in a very well-established diagnostic patients, you can refer your patient to anti-reflux surgery. You cannot refer a patient just because patient has hoarseness or chronic cough, okay? You need very well established reflux in those patients using the different diagnostic modalities, endoscopy, impedance pH, and manometry. If you have a patient with big hiatus hernia and atypical symptoms, yes, this is another indication. If you have a patient with severe erosive esophagitis, yeah, you can refer to the surgery, but this is the reason is not the atypical symptoms. The reason here, you can refer to patients because your patient needs surgery anyway, okay? Then this is their suggestion to refer to patients. I love this slide. This is my dear friend Michael Weiss's slide, published 2017. They look at the primary symptom recurrence post-fundoplication. If they check what is the primary symptom, what is the response to the anti-reflux surgery. If we have a patient with heartburn and regurgitation, with a PPI response, which is this group, okay, they have the highest responsive value. They give a very well response. Typical symptoms and PPI response, lovely group. Number two, suddenly drop a lot. Extraesophageal symptoms with PPI response. Even they response to PPI, if they have atypical symptoms, their response rate is about 40%, 35%. If you have a patient with typical symptoms without response to PPI, think again and again. We discussed before in the previous talk. But if you have a patient without any response to PPI and the only and solely symptom is atypical ones, never refer to surgery before all the diagnostic workups, okay? I really scared a lot for such patients. Okay, let's finish with these two algorithms. Those are the algorithms established by our team. Chronic cough and chronic LPR. If you have a patient with chronic laryngopharyngeal reflux symptoms, first exclude allergy, postnasal drip symptoms, smoking, environmental exposures, whatever they are, voice problems, cancer, post-infectious vagal neuropathy. Send them to the ENT. If there are LPR findings, then check whether there is any typical reflux symptoms or not. If there are typical reflux symptoms and LPR findings, this is actually our patients. ENTs can follow them up, but they should be treated according to our regulations. But there are typical plus atypical symptoms together. There are LPR findings without typical reflux symptoms. We suggest to use diet and lifestyle changes. Diet is debatable. Just stay away from very cold and hot beverages, alcohol, smoking, and lose weight. Those are the major ones. Don't use your voice a lot. This is what I say. Stay away from COVID and other infections if you can. Here we suggest them to start PPI, double dose of PPI, 2 months. But after this, we establish this one, we are putting the patient more and more double dose of PPI plus alginate nowadays. If there is no improvement, you are sure that this is the reflux-related atypical symptoms. Here in that case, we put them the different diagnostics such as pH impedance monitoring or upper GI endoscopy. If this is all normal, then we send them, psychiatrist, and we use some antidepressants, which there's a question regarding that, and then we continue. There are some very unfortunate cases which we cannot do anything. Chronic cough, same thing, everything first. Our colleagues from pulmonary medicine or ENT, they should exclude everything first, okay? They should exclude everything. Then we should take care of them. If everything is normal, if something is pathologic, then they should treat them accordingly. It's not my problem. But even though those are normal, we'll tell them check for upper airway cough syndrome, asthma, and non-asthma eosinophilic bronchitis. With all those technologies, if they are unresponsive, Then the same with the LPR. Go with diet, lifestyle changes, double dose of PPI, 4 grams of alginate, and maybe itopride. If they don't respond, then put them on diagnostics again. Always start with the high dose of PPI. 3 months, my friend. 3 months of PPI. Never make it shorter. And always taper the dose. Never stop the PPI immediately. Okay? Taper the dose. Let's say 2 times 40 milligram of pantoprazole, 20 or 140 pantoprazole, and the 20 pantoprazole, and stop it. This is how you should go. Okay? Best wishes from Ege Reflux Study Group. This is why we are working with the whole team: GI, ENT, pulmonary medicine, general surgery, psychiatry, and pediatrics. My friends, we are all working together. If I have a patient with chronic cough or hoarseness or whatever, I always refer my ENT and pulmonary medicine colleagues who are specialized also for reflux disease. And we have patient discussion hours once or twice a month. Then we call the patient inside the room, we discuss the patients, we learn the problems, and then we decide what to do. Again, I'm coming to Shymkent and Almaty, 13th and 14th of June. Hope to see you there. Those are the next meetings. With this one, we are finishing the talk regarding the reflux disease. Nobel team, are you going to put them offline? Please send me a message. I hope you put them. But we are going to talk more when I visit your lovely country. And the next one, 22nd of June, sorry, 25th of May, we are starting functional bowel disorders. Okay? 25th of May, please stay here. Let's respond to questions now. Okay. Okay, what are the questions and what I can say? Let me go one by one. Is there any question? Can you tell us about anti-reflux surgery, whether indication, long-term effect? Ainur is asking. Ainur, anti-reflux surgery is one of the gold standard therapeutic approach in patients very well-defined reflux. If they rely on PPI, if they cannot stop PPI, if you are pretty sure they have reflux, then please refer them to the experienced surgeons who can perform the anti-reflux surgery laparoscopically, okay? I don't send my surgeons with the open surgery, my patient to open surgery. How about the links? We don't perform links. You know, links, it's a technology with magnetic beads I mentioned in my previous talk, placed by and surgery. They also fix the hiatus. My friend, if they fix the hiatus, if they perform the surgery, all they are supposed to do is putting a fundoplication on top of it. Then who cares? Who cares? You know, what are we going to do? And in that case, I don't use links because it's pretty expensive. Questions. With a pulmonary form in the treatment, PPI or alginates bring a positive effect. Yes, as I just mentioned, yes, I use both together. I use the a combination of those two medications. Is it necessary to operate a cardiofundal hernia larger than 4 to 5 centimeters? The problem is how to measure them. How to measure them. Okay? Endoscopically, you cannot rely on them. But the best methodology in order to measure it is high-resolution esophageal manometry. If you don't have it, then send them to the barium swallow and ask the radiologist to report the size of the hernia. Okay, this is important. But is there any cutoff for the hernia size? No. But if your patient comes with a vomiting because of the turning of the hernia, suck, in that case, yes, please refer your patient to the surgery. It's too big. Yeah, my motility technician's aunt, grandma, she was 90 years old, 90. We refer her to the surgery because of a very severe vomiting symptoms. She lost a lot of weight. She is now 103 years old, something like that. Soon she's going to be 200 years old. How long should PPI therapy last in patients with chronic cough without esophagitis? You should go 3 months at least, in my opinion. And both. I mean, try to make it 3 months because this is a very sensitive or mucosa in order to effect of acid and pepsin. We do need a longer time frame compared to the esophagitis. What is the most minimally, okay, we discrete links. How long can I take PPI after fundoplication? Aysulu, Aysulu was here. Hey, Aysulu, good to hear from you. She was in our department. After the fundoplication, actually, we don't use it. Very short term, we use them. Afterwards, we just stop PPI because this is the main reason we perform the anti-reflux surgery, keep the patients away from PPI. Is tartar plaque related to GERD or duodenal reflux? A lot of patients come from dentists with these symptoms. They refer to the fact that this is a GI, there is no dyspeptic manifestations. Yeah, that's a big problem. Years ago, I tried to learn a lot the dental problems of reflux disease. Unfortunately, there is no way you can establish a clear-cut diagnosis between the dental problems and reflux disease, except children. Yeah, children, yes. Unknown reason of dental loss, they call it mine. If there is a loss of that, then you may establish a link. But that's possibly it's a very rare condition. Just few studies established. I don't think there's a relationship between tartar and plaque and the reflux disease. I don't recall any study regarding this, but I'm not saying that I know everything. Maybe there's a study. When I come there, let's discuss about that. 87 years old female has been suffering from GERD for 7 years of malignancy. Esophageal obstruction of the first stage. A biopsy of the esophagus and stomach show moderate cell atypia. Within 3 months, she took pantoprazole 40 milligrams 2 times. Effects of anti-reflux surgery, your opinion. How often anti-reflux surgery is performed in your clinic? Now, actually, the details are not sufficient for such patients. Why don't you send the details of this patient to Zanar and translate into English or Turkish? Then I read it and I'm going to give you an idea what to do. Or when I visit your place, we can discuss about this patient. We often perform anti-reflux surgery because we are running the largest reflux department in Turkey for sure. Dry cough bothers 3 months of CT scan of the lungs and bronchoscopy without pathology. Exposed for GERD after complex treatment of GERD, no effect. Also receive antihistamine. What is the further tactics? I'm not sure if I completely get the question, but you are saying that there is a dry cough, 3 months, CT normal, bronchoscopy is normal, and complex, what do you mean with complex treatment? But I think you are mentioning PPI and alginate, still no effect. What is the further tactics? Actually, here we are happy. What we do, we send them, we perform 24-hour pH impedance, okay? And look at the relationship between cough and reflux episodes. And then we establish a clear-cut diagnosis. Have we referred the patient to the psychiatrist? This is another problem. What I can suggest that, which there is a question about that, tricyclic antidepressants, which is named amitriptyline 10 milligram, you can use it. Or baclofen, be careful with the side effects. I have a very limited experience with that. You can also use baclofen in order to inhibit the reflex mechanisms and also getting better with the psychiatric comorbidities. Those are the possibilities I'm suggesting to you in such patients. In patients after resection of the stomach, anastomosis of esophagus intestine, suffering from severe heartburn, cause and treatment. Ooh, yeah. If we are sure that there is no stomach, in that case, if patient really suffering a lot, that means this patient needs Roux-en-Y anastomosis, or the bile should not come all the way to the esophagus. Maybe a Roux-en-Y anastomosis make the life of the patient is easier. This is all I can advise. Okay, possibly this is a type of B-Rot one is not a good term, but there is this anastomosis brings all the bile and pancreatic juice into the esophagus, and then this patient might have heartburn for sure. If you put a long arm and take all the bile and pancreatic juice and far away, about 40 centimeters away from the anastomosis, and then life will be easier. How long antidepressants used? 3 months. The expediency of manometry in newborns with pyloric stenosis and in children under 1 year old. No, I have no experience with newborns and patients less than 1 year old. I don't want to talk about that. It's not my humble point. I don't want to say anything about that. We talk about links. Link surgery is possible for patients with uncomplicated HERP, GERD, you mean, persistent uncured heartburn in the absence of the effect of conservative therapy. I have no objection with the link surgery. I have 2 objections here. Number 1, and studies are not bad though. Number 1, it's pretty expensive. It's free. Anti-reflux surgery is free. Why I'm supposed to send my patients? I'd rather to send my patients to ARM or asthma, anti-reflux mucosectomy or ablation, even stretta, which is much safer, non-invasive. Okay, in terms of links, while surgeon put everything inside the abdomen and suturing the hiatus, while you just perform anti-reflux fundoplication, they claim there is less bloating and distension in links compared to the fundoplication. You know, my surgeons are doing more and more toupet instead of Nissen. In that case, we see less and less gas bloating syndrome. As you see, I'm not a fan of this. Okay, thank you. PPI with a dry, last question, PPI with a dry cough. I said 3 months of PPI. The question is, should we drop after 3 months, the taper doses after 3 months, or stop the tapering from, let's say, after 4 weeks, 6 weeks? No, continue please with 3 months of double dose of PPI plus alginate, then start tapering the dose afterwards. Always go with full dose of 3 months. This is not a holy number, 3 months, okay? But we think that's a logic number. That's a realistic number of patients for 3 months. Again, that was a lovely meeting to talk with you guys. 25th of May, we are moving to very interesting topic, which is functional bowel disorders. And I'm going to talk regarding the different aspects of functional bowel disorders. It's always lovely to meet with you. Thanks for the lovely question. Okay, and hope to see you on 25th of May and 30 online, and 13th and 14th of June face-to-face in Shymkent and Almaty. And thanks, Nobel, for this lovely opportunity. Thanks, Maria. I think, again, she did a great job in order to translate this talk. Bye-bye. Take care.